Good morning, good evening, and good afternoon, everyone. I'm Benedict Walter from the Secretariat of the Network for Improving Quality of Care for Maternal, Newborn, and Child Health. Welcome to this webinar on using data for action. It is the fifth one in a series on transforming care for small and sick newborns, organized by UNICEF and the World Health Organization in collaboration with the Network for Improving Quality of Care for MNCH. You are all muted on entry to make sure the panelists can go through the presentation without interruption. However, we really want you to engage with them. So please use the chat box on the bottom right side of your screen to ask panelists your question. We have about 20 minutes dedicated to answering those questions at the end of the webinar. So please type away and we'll read them out at the end of the session. And we will also send you a link later today or tomorrow with this recording, as well as all the presentation and resource material that relate to this topic. I would like to introduce now to today's facilitator, Dr. Gagan Gupta, who is a health specialist at UNICEF. Please, Gagan, over to you.
Thanks, Benedict. Good morning, good afternoon, and good evening, colleagues. Wherever in the world you are at this moment in time, contributing in your own ways towards the global response to COVID-19. I'm Gagan from UNICEF headquarters in New York, your moderator for today's session. As the world this week reached the grim milestone of 10 million COVID cases and 500,000 deaths, along the way, it has also exposed glaring gaps in the public health systems of countries across continents and income groups. With more than 100 days into the pandemic, and with the fragility of routine data systems clearly evident, we are still forced to rely more on projections and models rather than the actual real-time data on the extent and impact of services disruption for mothers and newborn. And as the reluctance on sharing data is increasingly being reported from countries, the need for investment in data systems and ensuring transparency in data sharing is stronger than ever before. And this is what the focus of today's webinar is all about: use of data for action. This is the fifth webinar in a series organized by WHO and UNICEF on transforming care for small and sick newborns, along with the ENAP group and the Network for Improving Quality of Care. With more than 60 countries currently off track to meet the SDG target for neonatal mortality, care for small and sick newborn has to be our next frontier. 6 chapters from 94 authors across 6 continents is what it took to bring all the pieces of small and sick newborn together in this must-read global report. Today, we will be focusing on the 5th chapter of the report, that is use of data for action. And a large number of organizations and many of you working in the field have contributed to it. It has been a true collaborative effort between the global thinking and the local action. And for this, we have with us today Dr. Louise Tina Day. She's a pediatrician, obstetrician, and assistant professor at the London School of Hygiene and Tropical Medicine. And she was the one who did the most of the heavy lifting for this chapter. She would be presenting the key findings from the chapter. After that, I would be presenting the India experience of SNC online data, which now has an analysis of more than 5 million babies across 800 plus SNCs of India. We also have Dr. Alexander Manu, Senior Clinical Research Associate at the Center of Maternal and Newborn Health, Liverpool School of Tropical Medicine. He would be presenting the MPDSR experience from Namibia. And last but not the least, Dr. Ornella Linsetto, pediatrician and neonatologist, Senior Medical Officer for Newborn Health WHO, and a lead editor of the report. Ornella doesn't need any introduction. She has been the face of global newborn response for nearly a decade now. And she would be presenting some of the data which we have on the indirect effects of COVID-19. And thanks, Ornella, we're so lucky to have you with us. With this, over to Dr. Louise Tina Day. Thanks.
Thank you very much, Gagan. And it's my privilege today to share with you the Use Data for Action chapter from this report. How can we use data for small and sick newborns? Every country has data that can be used now to drive action. And in the previous webinars in this series, we've seen good examples of that. But as Gagan just reminded us, at this time of the coronavirus disease pandemic, we see more than ever our need for data and how fragile our data systems are. There are many opportunities to improve data for small and sick newborn, both data quality and availability. Gaps in high priority data must be closed to end preventable deaths, to ensure health and well-being, and change how small and sick newborns are cared for. Previous webinars in this series have shown us that neonatal mortality represents about half of all under 5 deaths. Small and sick newborns require special care to survive and thrive. Among 100 World Health Organization core health indicators, only one is specific for small and sick newborns: low birth weight rate. Policymakers need reliable, specific data for small and sick newborns to track progress towards the ambitious 2030 targets. So what data do we have that can be used now? This data pyramid figure illustrates which data are needed for small and sick newborns at different levels of the health system. Each circle represents a data point. Family and community are positioned at the base of the foundation of the pyramid as we focus on family-centered approach. The different colored circles represent all the different data for each individual child. Health workers use data for day-to-day clinical decisions and communicating information to families. But the health system can't cope with all those data. So the pyramid shows how only some of the data rises up the health system to facility, district, subnational management levels. And examples are shown in the table on the right. The data points in yellow at the center are the core or common indicators required for national and global tracking. And you can see many two-way arrows in the figure to illustrate the importance of feedback to improve data quality, both within the levels of the health system and between the different data points. Different types of indicators are used for different purposes. Every newborn action plan strategic objective number 5 is to transform measurement. This table shows the ENAP indicators. In the first column, the current status, heat map by traffic light. In the second column, the types of indicator, impact, coverage, and inputs. The third column lists the core ENAP indicators, and the fourth column, the additional indicators. Indicators specific for small and sick newborns are in black text, and the ones with a grey shaded out background are the ones that are not yet routinely tracked nationally and globally everywhere. We'll now look at each of those types of indicators in turn. First, impact indicators, used to measure results and track progress towards national, global goals and identify equity gaps. Data we have that can be used now includes neonatal mortality rate, ideally stratified by baby sex and birth weight groups. But more specific data are needed for small and sick newborns, especially gestational age, and a large gap is data to support follow-up for small and sick newborn survivors after inpatient care who are at high risk for developmental and nutritional poor outcomes. The second type of indicator we'll consider are indicators to measure coverage and quality of care to plan and improve services. Coverage indicators measure the proportion of small and sick newborns who receive the care they need. Quality of care indicators measure provision and experience of care. The data we have and are used now include contact coverage, typically tracked by nationally representative population-based or household surveys. And increasingly, content coverage is captured by routine health management information systems, such as interventions for newborns in health facilities. But again, more data are needed. Quality of care indicators that are refined, standardized, and validated. How can we measure, for example, right now at the time of this COVID virus pandemic, it would be so helpful if we knew better how we could measure unnecessary separation of babies from their mothers. We heard in the first session of this webinar this morning an example from Malawi, how they strengthened kangaroo mother care measurement. The key lessons were that they engaged the Ministry of Health leadership early and throughout. They prioritised indicators and data elements in routine reporting. They included facility and HMIS staff in design and testing of tools. And they planned and budgeted for the human resources that are needed to sustain the process. They collaborated across partners, and they also considered district-specific factors when assessing performance. This morning, we also heard a presentation from Silke Marder about how to improve measurement for parent and community engagement, which is absolutely central to work towards more effective family-centred care. At the moment, we have tools that measure parent and community engagement. And for neonatal units, even with options specific to their low-middle income setting, we have toolkits to monitor advocacy activities and results. But these tools need further developing and testing and even validation to measure the types of support received by parents, families, and newborns at this very stressful time when they have a sick child. It's always important to remember that behind every data point, there is a unique child. By measuring parent and family engagement, that reminds us of the place of those children within those families. Finally, we'll look at measuring health system inputs using the health system building blocks. Firstly, service readiness measurement. Periodic standardized health facility assessments measure across 5 domains: facility infrastructure, health technologies, care guidelines, human resources, training and routine practices. And you'll see on the next slide why these tools need further standardization to fully capture care for small and sick newborns. In this table, you can see the 3 tools that are commonly used, especially in low-middle income settings: SPA, the SARA, and the EMONC tool. At the bottom of the table, the boxes are green because those tools capture sometimes 4 or 5 of those domains we just mentioned. But that's for essential or immediate newborn care. Towards the top of the table, more complex care that small and sick newborns, babies require. The boxes are the table shows many more red boxes as the tools at the moment don't capture all of those domains. On the 5th line, effective phototherapy, which is a common intervention for small and sick newborns, as you can see, isn't captured currently by any of those 3 tools. Secondly, health management information systems are important to guide action at all levels within the health system. We've already considered the data pyramid a few minutes ago, and the rapid expansion of electronic platforms has potential to unify and align traditionally fragmented information systems. And we've discussed what proportion of the core or common newborn indicators specific for small and sick newborns are currently being tracked. But more data are needed, especially improving data quality through feedback loops, as we mentioned. We need data that can track individual newborns longitudinally, link them to their mothers and their own life course. We need standardized neonatal inpatient records and implementation research designed to strengthen the relationship of data systems and data use. In a few minutes, we'll hear from Gagan Gupta about the real-time monitoring of the newborn care units in India. Thirdly, we need data that can measure health workforce to shape policies and plan adequate numbers of suitably trained health workers for this provision of inpatient care. Currently, this data is relatively limited, but we need robust data that tracks competencies, staffing ratios, recruitment, deployment, rotation, and migration patterns. And also, we need to learn how we can measure the experience of health workers caring for small and sick newborns, and how the health system has capacity to support them as caregivers. Fourthly, we need measurement around health systems finance, to plan services, ensure access, and determine who is paying. And finally, in measuring inputs, we must remember, how are we measuring leadership and governance? Sustainable Development Goal number 17, Revitalize Global Partnership for Sustainable Development, has a specific target to increase availability of high quality, timely and reliable data. So we've thought a little bit about what data we have and can be used, but of course there are many opportunities to improve and use data right now. We'll focus on three. Firstly, in civil registration of vital statistics, small and sick newborns are often underrepresented or missing. Small babies are low birth weight, and this graph illustrates how the gap in the birth weight data that's available in routine systems. There are four groups: global, developed country, Southern Asia, and Sub-Saharan Africa. And the red bars show the proportion of births that are within facilities, the blue bars, the proportion of births that are registered, and the yellow bars, the proportion of birth weight data available in routine systems. If we focus on the least developed, the second group of bars, you can see that although more than 50% of births are in facilities, 12.8% less babies get registered, and another 46.5% less babies have birth weight data routinely available in those countries. This is the kind of data that we need to urgently improve. Many of those babies will have been weighed at the time of their facility birth, but that data isn't available for tracking low birth weight rates. Secondly, in a few minutes, we'll hear from Alex Manu presenting about MPDSR and how that data can be used for action now. And then thirdly, improving data is particularly important for improving quality of care measurement. We all know that counting alone isn't sufficient to change practice. The data needs to be used for action to implement solutions. And we've highlighted here the Quality of Care Network's monitoring framework, which guides quality improvement implementation and the use of data to track outcomes. Gaps in data must be closed to transform care so that all newborns can survive and thrive. And that's especially true for babies born in humanitarian settings, who are the most vulnerable small and sick newborns on our planet. Yet we have the least health-related data available for them. For universal health coverage, we need to increase data availability and link humanitarian setting data with stable, even host communities in the same geographies. So the chapter ends with prioritizing a few data for action for small and sick newborns. Firstly, to survive, we need to use HMIS integrated coverage and quality of care indicators. We need to link individual standardized clinical records for newborns to comparable core data sets. And we need to standardize service readiness tools to include small and sick newborns. Secondly, to thrive, we've discussed standardizing indicators linked to child development and nutrition for high-risk small and sick newborn survivors. And finally, to expand enabling environments, we do measurements that are improved for small and sick newborns in all settings, including humanitarian, and particularly to measure experience of care for newborns, families, and providers. I'd like to acknowledge all the other co-authors on this chapter, managing editors for the report, and for help with the PowerPoint slides and the graphics for this report and presentation. Thank you. I'd like to hand over now back to Gagan.
Thanks, Louise, for a very comprehensive presentation. And now we move to India. Over the next 5 minutes, I will take you through the SNC online story of India, a story which not many believed a few years back could be written by a low middle income group country like India, to virtually breaking the glass ceiling by reaching 5 million newborns last month. It's also a story which moved from a UNICEF pilot in a few districts to a national scale-up using government resources, and is an example of a strong government leadership. Next slide, please. The story of India is often spoken as a story of large numbers. It's a story of 25 million babies born each year, by far the largest birth cohort. The second biggest is China. Given the fact that India has a high birth cohort and a modest neonatal mortality rate, the narrative that India has the highest number of neonatal deaths is not going to change for several years. But what is changing is the share of India's burden of neonatal deaths to the global burden. In 2000, India was contributing to 31% of the global deaths, and it has now reduced to 22% of the global burden. The share of neonatal to under 5 deaths still remains high, with 64% of the under 5 deaths being the neonatal, and this is much higher than the global average of 47%. Next slide, please. The story of India is also a story which is shifting from homes to hospitals, with every second woman delivering at home in 2005 to now 8 out of 10 women delivering in the health facility. There was an urgency to invest in the care of small and sick newborn, and so did India, with 850 plus special newborn care units covering more than 90% districts. But with 1 million newborns being treated each year in these newborn care units and an annual investment of $90 million, the biggest challenge we had was there was no system to monitor the outcome. To address this challenge, next slide, please. To address this challenge, we piloted the SNCU online monitoring system in the 2 newborn care units in remote districts of central India in 2012. That was the first moment of shifting from standalone SNCUs to a more comprehensive SNCU online and SNCU follow-up system. The target was the SNCU staff, the program managers, and the policymakers. It had analysis on more than 250 plus parameters, and the focus was how can we use data to monitor and improve performance. And this was then scaled up by National Health Mission and Government of India through the national funding across 800 plus SNCUs. And now we have more than 5 million babies registered with 495,000 deaths. This is now the largest real-time online data system for small and sick newborn globally. Next slide, please. So just to give you in a nutshell what it is about, there are 2 major components if you want to set up a data system in your newborn care unit. The first thing you need to bring is a uniform data recording system. Initially, all newborn care units were recording different variables. So if you want to shift to an online monitoring system, the first thing is all the newborn units in the country or in the province or in the region should be recording the same variables. So standardizing the admission sheets, the discharge sheets, and the referral sheets was the first step. And the second thing was there was a simultaneous online entry of this, which can be done by a unit staff, or you can have a dedicated data clerk for this. India started with a dedicated data operator, and both these components were funded in the district and the national plans. So there was a dedicated line under the newborn care for data monitoring and data systems. Next slide, please. Now, second most important thing is once you set up the system, how do you use this the evidence which is coming out for advocacy and action? And I will just give you a glimpse of this over the subsequent slides. Next slide, please. The first thing is about access. India started a very ambitious program called JHSPH, which provides for free transport, free care, and free diagnostics for pregnant women, newborn, and children up to 2 years of age. But in spite of that, the access for the girl child was less. If you see in 2019 alone, there were 194,000 fewer female admissions in the SNCUs in spite of the free care from the government. And this brought forward the need of addressing the care-seeking behaviors at the community level, the need for addressing the out-of-pocket expenses like wage loss compensation, because when a child is admitted for 7 to 10 days in a newborn care unit, there's a wage loss compensation that needs to be given. And then the state started taking strong actions to address the issue of improving the access to the girl child. Next slide. The second thing I would like to take is about quality of care. And this is the data on the asphyxia deaths of last 6 years from the newborn care units. If you see the total number of deaths in the category of above 2.5 kg were 117,500 in last 6 years. First of all, a 2.5 kg plus baby should not be coming to a newborn care unit. And if the baby is coming, the baby should not be dying. And if you see what was the main cause of death in the babies who were above 2.5 kg, came to the SNCUs and died, it was birth asphyxia. 2 out of 3 babies in about 2.5 kg die because of asphyxia. And the interventions are well known: skill attendance at birth, the emergency obstetric care, and the neonatal resuscitation. Now, to address this, when this data came, the government of India launched a very ambitious program called Laksh. It's a labor room quality improvement initiative. It also covers the newborn care units and the postnatal ward. So this is the way the data and the need was also matched by a parallel action by the government of India. And this Laksh program is nothing but the whole quality of care bundled together. Next slide, please. Another thing on antibiotic use is, if you see the antibiotic usage for last 3 years in the SNCUs, at the national level it is 51%. But what is interesting was that this data system also showed the antibiotic usage at the state level and the district level. And you can see in the spectrum there are states with 81% antibiotic usage to states with 30 to 35% antibiotic usage. And what was more important as action was then this data was used to give the feedback to the states and the districts. And on the right top of the screen, you can see a snippet from the National SNCU Fact Sheet of 2017-18, which highlights the 5 states with the highest antibiotic usage and the oxygen usage as well. And the 51% antibiotic use is the cumulative average for last 3 years. But currently for 2019, the antibiotic use has now come down to 46%, while in 2016, it was around 58%. So already there is a 20% decline in the antibiotic usage at national level by regular monitoring and review of data. Next slide, please. The fourth important piece of evidence which was used from this data system was the need to invest in the community follow-up of the newborns. The care still needs to be provided after discharge, because 1 out of 4 babies who are being discharged from the newborn care units are still below 2 kg. That means there's a need for hypothermia prevention, feeding support, hygiene, and investment in optimal development. And this piece of evidence then contributed to initiating a follow-up system in the community and at the facility. Next slide, please. And that brought the whole gamut of extending the continuum of care back to community and homes, the place where they come from and the place where they go back to. Next, please. And this is what was put in the program: a strong component of counseling and screening on discharge, and the home visits by the ASHA workers. So the whole protocol of home visit was then shifted from the day of discharge, 6 visits, day 1, 3, 7, 14, 21, and 28. It also included a component of SMS reminders and telephone calls to the community workers and the families. And this was backed up by 5 hospital visits in the first year of life. So a combination of 6 home visits and 5 facility visits was included as a part of the SNCU follow-up. Next slide. And I would just like to put some indicators and show you how this data has been looked at and how it has helped to improve the quality of care indicators. If you see Maharashtra, state with 110 million population, the antibiotic usage came down from 72% in 2016 to 46% in 2019. If you see Uttar Pradesh, the state with 200 million people and highest number of under 5 deaths and neonatal deaths in the country, the mortality in the SNCUs declined from 14% to 9%. Rajasthan, another state with high neonatal mortality and 70 million population, the scheduled follow-up when we started was less than 14%, and now it is increased to 35%, though this is one of the areas where a lot of work still needs to be done. Next slide, please. So as I conclude, what helped us? First of all, being pragmatic and bold. Second was the intervention actually addressed the need on the ground. And this is another example when strong government leadership backed up by the right partner support and a right intervention is there, then it can be scaled up very fast in the system. Another important thing was seeing is believing. When we started with few districts and the first state was fully saturated, we took it to Government of India. And the Government of India was a part of this co-creation. And before that, the states were the part of the co-creation. And when states start presenting their data, the Government of India felt that this needs to be scaled up across the country. And then there was a strong leadership by the government and the ownership by the states because they were looking at their data vis-a-vis the other states. Ensuring a dedicated funding and a dedicated data operator really helped. Regular review and feedback to districts. And if you see on the right side of the screen, this is the national fact sheet for the year 2017-18. Similarly, there were state fact sheets and district fact sheets. So all this data was reviewed, a feedback was given till the district level, evolving and adapting as per the emerging needs. Like a couple of years back, we also started now including the private sector data in one of the states. So in the state of Gujarat, more than 100 newborn care units are now reporting the private sector data. And lastly, exchange across countries and partners with countries like Nepal, Afghanistan, Bangladesh, countries like we had Nigeria coming to look at it. The whole team of the Nest came and looked at it. So this is the way this is also being used to spread how the knowledge can be looked at in different countries. So with this, I think over to the next speaker, Dr. Alex Manu. Thank you so much.
Thank you very much, Dr. Gagan. I am presenting on Namibia's journey to MPDSR. And for Namibia, as you will know, we wanted to look at how data informed this journey of Namibia in MPDSR. So let me move to the next slide. Okay, so to start with, since we are discussing data, we started by looking at what does the data say in Namibia before we were starting the PDSR process. So first of all, at the time that we were starting, perinatal death surveillance and response systems were non-existent. There were death review committees in some facilities, but they were often maternal focused. Recommendations made from these meetings were not implemented, and so the challenges that led to deaths recurred. And so staff began to get frustrated and felt that why should I go for these meetings and not have any outcome? And then we were thinking about introducing perinatal death surveillance, which is looking at the newborn baby and also stillbirths that were occurring. And we wanted to build on the existing system, but this was a system where the foundations were said to be weak to start with. So were we going to fall on these foundations to build anything, it probably would not have stood. And so like always, there were also challenges with counting. So when a baby is born, for example, in the labor room and the baby breathes for a few minutes and dies, it is not captured in the gynecology story as a stillbirth, and it's not captured in a newborn ward as a newborn death. And so sometimes these babies fall through the cracks. So the counting was an issue. So right from the beginning, we were clear that if we were going to address these things, then the data must inform what we do. So we decided that the strategy for implementing a technical support to the country was to have 3 incremental jumps, and that is what it ended up being, informed by data. So we started with the hands-on training, and this was in May 2019, last year. So we had everybody, as you can see in the picture, coming together, doing the training, working in teams from the main hospitals that take care of about 80% of all deliveries, and for that matter, deaths in the country. Then after this training, we were believing that the sites were enthusiastic enough to go and start. But we were also collecting data on the background. How many of them have been able to initiate action based on a roadmap that we set out for ourselves? Now the data told us that nothing was happening. So then we thought that, okay, why is there nothing happening? And some of the feedback we got was that almost all the facilities that were trained thought that they did not have a critical mass of people trained to be able to lead the action. And they also felt that they were not in the position to replicate the training. So they needed more support to have a critical mass to lead the process. So that data brought us together again in September for another training session. But in September, we added another level where we said, sometimes when you talk about data, you say that this facility has been able to conduct weekly perinatal death review meetings, and they've done it over the past 3 months. It's difficult for people to conceptualize. So sometimes they want to see it with their own eyes. So we had one facility that was moderately doing very well, and we had all the participants go in there to observe them conduct a review meeting. It was so empowering. Everybody thought that, okay, this is the time that we need to move. And in the subsequent slide, you would see how this impacted on the system. Then in November, we went on for hands-on follow-on support to the facilities where they were working. So what happened? If you look at 3 main facilities in the country, these are referral hospitals or intermediate referral hospitals in the country. If you look at the 3 slides, the red is perinatal mortality, the yellow is the stillbirth rate, and the green is neonatal mortality rate. If you look at this, it doesn't tell a big story. The training finished, the first training was in May, and if you look at July to December and on into this year, then you would say that nothing is really happening. But usually these averages never really tell the entire story. And this is a key thing, that if we want data to inform interventions, then the data must be directed, and it must be an intentional data collection. And Louis and Gagan said how some of the data were stratified to inform how the focus of interventions come into play. So let's look at the charts. And this is the trend in neonatal mortality rate, institutional neonatal mortality rate in one of the hospitals. And if you look at this, it looks like it's a zigzag. But when I start putting the story to it, you would see what is happening. So in the first 3 months of 2019, the mean perinatal, this is neonatal mortality rate, sorry. The mean neonatal mortality rate was 16.1 and the median was 18.1, just for the first 3 months, just so that we can compare with the first 3 months of this year. But then we had our training at this point. But if you can see, it does look like from a high of 24, which is a low and middle income country, the mortality rate has started falling, or appears to be falling, to levels that were like in the United States of America, or even some of the more developed countries. But the challenge was that we said, how is this happening? Nothing happened at the first training, as I said earlier on. And so with that data, we had a second training, which was in September. This time, the focus was on data quality and implementing recommendations. And as you can see, immediately there was a jump. And even when it fell, it didn't fall to the bottom, but you would see it hovering around there. So for the first quarter of this year, the mean neonatal mortality rate is around 12.4, and the median is around 13.2. So you can see that the strategy was for this to inform the data to inform the actions that were being taken. Now, one of the key things that we also introduced to help with the implementation was for them to be able to monitor the response component of the perinatal death surveillance and response system. Because when the recommendations are made and they are not followed through, who follows up to know what is happening? So we had a simple Excel spreadsheet that hasn't got any online functionality. You have it offline, and then you upload the data in it. And it tells you several things about which recommendations have been made, How many of them have been followed through? How many of them are pending? And how many of them have failed, have fallen through? And you can see that the facility that I showed is clearly showing green all through because most of the recommendations that they have made have been implemented. The two in white are those that are pending and are not due for review. But it's not only the quantitative data that tells us where we are going. Sometimes if you have qualitative data, it could serve as an advocacy tool for the teams to be able to improve the quality of care that they provide for small and sick newborns. So there were two facilities who decided that, okay, we have data now. We can use this data for advocacy at the regional health directorate level. And this has earned them the opportunity to have people go for skills development, including fetal monitoring training for women in pregnancy and in labor. And they've talked about this story here where they had a woman who had preeclampsia or eclampsia, and the woman died right in front of them, and they could not do anything about it. But when they went for the review meeting, they thought that, okay, we could have tried to save the baby. So the next time they had a similar situation, they were successful in saving the baby, even though they lost the mother. So this, they thought, was how the data from what they have learned in the past have motivated them to do things differently. So I would say thank you to everybody. But before I go, I would say that you might not have all the data that you would need. You might not have all the resources to establish systems to collect the data, but the little data that you are collecting, if you are systematic about it and you focus the data collection, you would always find useful decisions that are made from the data that you have. Start small and be informed by the data. The second thing is that once you start using the data, once you look at the data to look at what is the data telling me, and you start challenging the data, you start improving the quality of the data. And it is only when the quality improves that we will then know where we are and where we want to go. And that should be the focus of data for action, that we need to have a goal. And once we have a goal, we know where we are going to. Thank you very much. And I hand over to Gagan again.
Actually, we're handing over to Dr. Ornella Lincetto from WHO to present a few slides on the COVID implications.
Thank you. So should I put the slides so they come through Luis?
Sorry, my mistake, Luis.
So good afternoon to everybody, and thank you very much to the previous presenters, and because they make my life easy now on reflecting a bit on the use of data for action when we are talking about the COVID-19 pandemic. And we heard all countries collect data, and in fact, we are using the available data also to understand more the impact of COVID-19 on various populations, including the newborns. And as mentioned in the previous webinars, there are, the newborns are in general at low risk of COVID-19 in terms of direct effects compared with other population groups, age population groups. But in fact, the newborns are, are rarely affected, and when they are affected, they have mild disease or asymptomatic disease. But they are much more affected from indirect effect, basically. And so if you can see from this slide, this is just a snapshot of some countries on the left side and the key maternal neonatal services. Without looking at the details, you can see there is a lot of yellow and a lot of red, which represent the disruption of essential services, basically. But how to measure this disruption and how to measure also the causes that of in services. Next slide. So there are a number of factors that are causing these disruptions, and we are trying to measure them. Certainly some are related to health system capacity loss, but many are also in other domains, which are a mix of government and individual decision. For example, the first line where 79% of a very much represented cause, let's say, is more related to the patients just not coming at outpatient services. Or the second, you can see 63% of reduction is due to the consequences of lockdown and difficulty in transport, or financial barriers as well, 48%. But while, but of course, there is all a set of causes that are impacting on the access to services. Next slide. But if from a point of view of measurement, we have a number of challenges. First of all, especially if you want to measure the impact of COVID-19 on newborns. So first of all, we heard the low middle income countries don't have a strong monitoring system for newborn care. And from the INAP progress report, the most recent one, we know that among the 90 countries, low middle income countries that have responded to the survey, 41% only have a birth registration in their health management information system, and with only 22% having a perinatal death review indicators in their health management information system. We also have less than 50% of our countries with a perinatal death review response system, and as well as many having limited use or limit of indicators to assess both impact as well as quality and equity. So this makes difficult and challenging measuring also the impact of COVID on newborn. Then we have another challenge is posed by the fact that we don't know much yet on the effects of COVID-19 on pregnancy and neonatal outcomes, because the disease is new and we have only, pregnancy. I mean, disease started a few months previous year. And so we have only a small cohort of women who are in their first trimesters, for example. And then the indirect effects depends also many factors that require measurements that some of them are not lying in the health system but beyond the system. And finally, we have competing priorities due to COVID pandemic that may divert monitoring resources to other age groups or services. Next. So what has been done so far? Next slide, please. So what has been done so far is related to strengthening, of course, the research to be able to understand better the disease. So WHO started already in February to develop with the partners a roadmap to accelerate the research on COVID-19. There are now, this slide is from May, so it's many more than 700 clinical trials underway, which and we use the data to develop the recommendations both for clinical care and for programs, using independent panels with the research to which this the researchers take place, contribute. And then we have you heard certainly about the solidarity trial that was launched by WHO and partners, and now has a high number of patient enrolls from more than 100 countries. And the Tools Accelerator that is also an initiative to make supplies, medicines, vaccines, etc., more on research and access to these technologies for in an equitable way to countries. And then finally, next slide, there are a number of activities going on exactly for measuring and modeling. And one is, of course, the collecting data from the countries, because countries are reporting regularly to WHO, and so on the status of the disease. And so we are analyzing the data and preparing situation report and the dashboard that you can access them regularly. And then we have rapid surveys is another way of getting information from countries, particularly from on the disruption of services. And then we have specific research, as I said before, but for what concerns the newborn, there is let's say, an initiative specifically, which is a research, the COVID-19 Research Network for Maternal, Neonatal, Child, Adolescent Health, of how do you say, lines of research for that include also neonatal outcome. For example, the cohort studies. There are cohort studies on pregnancy that are looking also at fetal and neonatal outcomes. We have studies on infant feeding. We have the cohort study on child health. And then the clinical characterization studies, because for newborn, it's true, is not affected very much, but it's also true that has not been studied very much, the COVID in newborns. So there is a line of research on understanding really the clinical characterization of COVID-19 in newborns, and in order to be able to understand better the disease, and also to differentiate COVID from other neonatal conditions. And what else? Then there are the modeling. Modeling is also very important, has helped us. I'm sure you have read the results of the list studies that were on the indirect effect of COVID-19 on maternal, neonatal, and child health using the list methodology done by the Johns Hopkins School of Public Health. And then ongoing are also simulation of COVID-19 risk in different type of scenarios for done by IDM.
Ornella, we need to wrap up because we only have 10 minutes left for the questions.
Oh, okay. Yes, and then so just to conclude is that as we need to, as we do, we strengthen our efforts to understand the COVID, we need at the same time to continue to strengthen measurement for newborn indicators, because the data on neonatal deaths, gestational age, birth weight, as well as we cannot understand direct and indirect impact of COVID. And we need also to understand the quality and coverage in order to be able to measure neonatal services in general and in relation to the COVID-19 epidemic. Thank you, and I hand over to Ben in this case.
Thank you very much, all of you, for today's session. We have quite a lot of questions for Louise to start with. One of them about mentioning that there is many data indicators where the recommendation is to use them in combination for a composite index in facility. Is there any experience of using composite index for small and sick newborns in facilities?
Thanks very much for the question. And just from my side, composite indicators are great, but they are by sort of definition quite complex to measure. Gavin, can I just ask you, have you tried using them in your India special care newborn units?
Sorry, can you please repeat?
Gagan, I was just interested, did you try using composite newborn indicators for the special care newborn units in India? Did you find them helpful, or did you try them?
Yeah, so we also had this kind of a scoring using the composite indicators. And the biggest problem what we find is that how the countries and the districts are using the data for their own improvement. Because many of the times the districts which were using the data, they were not actually using it for their own improvement. And that was the initial challenge. But later on, making sure that this is being used, and we also had a scorecard, which we work with partners on that. So that helped. Over.
Louise, we can't hear you.
Well, thanks so much, Gagan. That's helpful. Back to you, Benny.
Okay, another question for Louise. What are the major challenges to collect the data of gestational age in low and middle income countries like Bangladesh, when first ANC is delayed and pregnant women can't remember their LMP? How would you resolve that?
Yeah, thank you. That's a very good question. And I think we already saw examples today of how important it is to link small and sick newborn care with the continuum of care and working to improve antenatal services to get accurate gestation. But in the meantime, babies' gestational age can be assessed clinically after birth. I think also we just need to spread the message that doing late ultrasounds and using those dates for gestational age is really risky. And as cesarean sections rise particularly, delivering a baby on an inaccurate gestation is very risky and will actually increase small and sick newborns, unfortunately. So I think, yeah, both ways, improving accurate and also being very, very careful with inaccurate gestational, and then using clinical assessment after the baby's born can be helpful. Thanks.
Another question for you, but also probably for Gagan. A participant requests to share your thoughts on how country could integrate developmental assessment and indicator within SNCUs and community data collection system so that the development delays are identified early on for early intervention. Do you have tested indicators for that? If not, is anyone working on this?
Right. So I think there are a few things that can be looked at. One is the screening at the time of discharge, especially for the retinopathy of prematurity and hearing, especially in those babies which have been subjected to oxygen or who had a very, unstable course during the treatment and who are extremely preterm. In addition, there are certain indicators which you can look at the follow-up, which can be the motor milestones and the other cognitive development milestones. Currently, we have only a few of them, but they can always be incorporated depending upon the capacity of the system to do first those screenings and to report on that. Over.
Thank you. Two more questions for you, Gagan. One participant is curious to know how the SMS reminder works in community follow-up, and did this project introduce any post-discharge phone follow-up intervention in community level, at the community level?
Right. So the primary follow-up is through the phone follow-up. Basically, one of the roles of the data operator or the data clerk is to also make calls to all the families who are due for follow-up. So at the time of admission, the mobile numbers of the family or someone in the community who are having the cell phone are recorded. And there's also an alternate number recorded because many times people do change their mobile numbers and then they become non-traceable. Also, there is an inbuilt mobile number of the community health worker. So both the community health worker and the family are reminded a day before the follow-up. And then in some of the states, they also went for an SMS reminder where the SMS is sent to the families both on the day of follow-up and at the time of discharge to the community worker that this baby is being discharged from the newborn care unit and is arriving in the community and is due for home visits. And the system auto-generates those schedules for the home and the facility visits based on which the data can be fetched by the mobile operator and the SMS can be sent. But largely it's dependent on phone. Some of the states have gone ahead with the SMS reminders as well. Over.
Very quickly, three more questions. One for you, Gagan, the last one for you. Facility registers of birth and neonatal care are notoriously inaccurate, duplicative, and laborious to complete. How are the lessons learned from initiatives such as the one you described in India, SNCUs, being applied more widely to rationalize data collection for frontline workers?
Right. So I think it's a very valid point, and this is a problem across continents. But one of the keys is that don't try to record everything under the sun, because sometimes what happens is everyone wants to chip in an indicator and everyone wants to put in the things, but there's the same health worker who has to put everything in those records. So keeping those indicators which are going to also help you in decision making helps. So we try to keep the bare minimum number of indicators in these recording formats and reporting formats. Within that also, we introduced some of the auto checks within the system. So while you are entering the data, and the system will pick up some errors on its own and would flag you that, please relook, the data does not seem to be consistent. Same way, there was also a system where we were looking at some of the indicators like timeliness of data collection and the quality of data. So the system will give you the inbuilt report of what was the lag between the patient admission and the patient's data entry. And then what we also did was we did not make all the indicators mandatory, because the final journey was to have all the data which is available. But in the initial part, we made a few indicators which were critical, without which it will not let you save the data, like the birth weight, the diagnosis, the cause of death. But there were certain indicators in the whole antenatal history or the intrapartum history which might not be readily available. So those were indicators which were kept as open-ended indicators, but not mandatory that it cannot let you save the form. So these are the issues, probably the way we dealt with,
Thank you. Take one more, then we need to close down, and I'll ask the panelists to answer the remaining question on the website, to which link I'll send you a link later today. For Nella, what is specifically being done to track stillbirth, especially intrapartum stillbirth post-COVID?
What we are doing now is more, I think what will be more useful. I mean, there are two things. One is the leading systematic review that are taking place. And so this is so we collect data from different reports and studies. The other one is the cohort studies, where actually we are following up women, pregnant women. So these are the two main systems to collect the data on stillbirths and COVID.
Thank you. I will now hand over to Gagan Gupta to close this session. Thank you.
Right. Thank you so much, Benedict, and thanks to everyone for joining today's session. And I would also like to acknowledge my colleagues, Dr. Sanbab, and the former colleague Nabila, who was a critical part of this report. And we also have Lily amongst the audience, who was very critical for pushing for this report. Just two key messages as I close. When we talk about the resilient health systems, the need to have a resilient data system is felt much more than ever before, and we need to invest on that. And second is, taking data systems for scale is feasible, but we need to be pragmatic, start small, but think big. And with this, I would just like to remind you, for the next webinar, which is scheduled on 15 July, immediate action is needed. That would be the 6th webinar in the series. Please join in, and thanks, and have a good day, good evening. Over.
Thank you very much for your participation, and have a good day. Bye.